Hi, my name is Dr. Juliet Sekabunga and I am presenting the head trauma session of this Kampala Advanced Trauma Care course. We'll look at our outline today. We'll look at the global context, epidemiology, both local and international, the main principles of treatment, the anatomy and pathophysiology, management strategies, ideal treatment, adaptations for resource-limited settings. Here we'll be looking at what would happen in a setting. The global context. Traumatic brain injury global incidence is estimated at 939 per 100,000 people, and it's thought that about 69 million people will suffer from TBI each year. Worldwide, commonly caused by motor vehicle crashes. In our setting, usually the motorcycle crashes, falls when it comes to children and the elderly, and then violence, especially in the war-torn areas. The highest prevalence has been seen in the second and third decades of life, with the highest mortality rate between 15 to 24 years, and in patients with severe traumatic brain injury. Increased risks of TBI is seen in the young, the unmarried, men, history of substance abuse, and history of previous traumatic brain injury. Not to forget, 20% of the traumatic brain injuries occur in the pediatric age group, and we remind you always that the pathophysiology and patterns of injury in children are slightly different from those that we've seen in adults. That we shall discuss when you come to rotate through the neurosurgery ward. So here we want to look at the main principles of management. Our primary goal is to prevent secondary brain injury. So just a recap, primary head trauma is what occurs at the time of injury. Here we are looking at skull fractures, we are looking at hematomas, contusions, we are looking at concussions, and diffuse axonal injury. However, secondary injury occurs within hours, days, or even weeks of the primary head injury. We need to provide adequate oxygenation, maintain the blood pressure at the level that's sufficient to perfuse the brain. We'll look at this in the physiology. Obtaining a CT scan should not delay patient transfer to a trauma center, and consult a neurosurgeon early before you leave the neurosurgery ward. Endeavor to at least have a phone number or anything, an email of one of the neurosurgeons, just in case you need to have some of these early or emergency techniques to do while you're waiting to transfer your patient. And remember, before you transfer the patient, call and find out who is present, so that it makes it easier for us to know that there's a patient that's coming in, and prepare for, do they need surgery, do they need this. It becomes easier when you inform us earlier. Anatomy and physiology. So things to recall: the scalp has an extensive blood supply. Remember the supraorbital artery, the superficial temporal artery, and the occipital artery. And when it comes to lacerations, patients have really lost a lot of blood from these. And in pediatrics, when you see a scalp hematoma, do not hesitate to do an urgent HB check, because we found children having HBs of 8 and even below from a hematoma from the scalp. Remember, the skull is a fixed compartment. Injuries could be due to acceleration or deceleration, or it could be direct impact, things like the use of metallic objects, or in children, who accidentally hit either a door or a refrigerator or something, and therefore you have a skull fracture. Meninges, not to forget, you have the dura, you have the arachnoid, you have the pia. The dura contains venous sinuses. It contains bridging veins that connect cortical veins to the dura venous sinuses, and the bridging veins can tear. The venous sinuses can be injured, and therefore you have either epidural or subdural bleeds. The meningeal artery, that the middle meningeal artery actually is one of the commonest arteries that is injured. It's close to the thinnest part of bone, of the temporal bone, and it causes all the way, it fans out on the dura in the frontal, temporal, parietal areas, and therefore when there's a fracture, you're highly likely to have either a frontal, a temporal, or a parietal hematoma. The brain. What's traumatic brain injury? So it's usually an acquired insult to the brain from an external mechanical force. It can lead to temporary or permanent impairment in cognitive or psychomotor function. So some of the aftermath of head trauma can be temporary, and for some people it can be a permanent damage. That is why we insist on ensuring that we prevent secondary head trauma. The ventricular system. Remember, the arachnoid, the subarachnoid space contains the intracranial vessels, and therefore when they are injured, blood spills into the subarachnoid space, which also contains CSF, and therefore it's clogged either in the ventricles or in the reabsorption areas of the brain, which is the arachnoid granulations. And when it's clogged here, we may have ventriculomegaly, and this may end up into increase in intracranial pressure. How about the intracranial compartments? What about them? We have to remember that we have the supratentorial compartment, we have the infratentorial compartment. These are separated by the tentorial opening. So now we begin. How about ankle herniations? So here, the anchors of the temporal lobe herniates through the tentorial opening. And we have to remember that the third cranial nerve actually runs below the anchors of the temporal lobe. So it's the first to be compressed, and when it is compressed, we have a unilaterally dilated pupil on the side of the compression. So unilaterally dilated pupil, side of compression. You just have to remember, if I find a left pupil dilated, the compression is definitely on the left side. But do not forget, there are other things that could cause a unilaterally dilated pupil. We have seen any injury to the midbrain, especially when we are talking about diffuse axonal injury. Any injury to the cavernous sinus, if it's unilateral, it will definitely cause a pupil dilatation because it's the same side issue. Subfalcine herniation. Here the cingulate gyrus herniates through the free edge of the falx cerebri, and the artery at play here is the anterior cerebral artery. The anterior cerebral artery supplies the leg area of the motor cortex. So if you have a patient and they have weakness of their leg or lower limb, the first thing you could think of is probably a cingulate or subfalcine herniation. Transtentorial herniation is herniation of either the supratentorial components down into the tentorial opening, or the infratentorial components down into the tentorial opening. So transtentorial usually is like a cascade. So the supratentorial components, as they herniate through the tentorial components, the posterior fossa becomes full. So there is need for space. So what happens is that the cerebellum especially the tonsils, and the brainstem will herniate through foramen magnum. At this point, there's compression of the brainstem, and therefore we'll have patients having raised intracranial pressure because the sympathetic nervous system center is within the brainstem. We have bradycardia, and then we have abnormal respiration. Remember, the cardiovascular centers, the respiratory centers are in the pons and the medulla. So that would explain the effects with the blood pressure, the breathing, and the pulse rate. And calvarial herniation is basically when the brain herniates through the calvarium. We see this commonly in depressed skull fractures. So physiology. What's intracranial pressure? So what's the normal? What's the abnormal? So we usually say that in children it's 0 to 6, while in adults it's 5 to 15. However, there are instances where patients or people, normal people, may have raised intracranial pressure, especially those who are straining, coughing, or sometimes we just find people with a bit of raise. They may go up to 20 as a normal pressure for them. In head trauma, however, when pressures are above 20 and they are persistent, this is usually associated with poor outcomes. Cerebral blood flow, very important. We'll look at that in the next slide. But we have seen in severe traumatic brain injury especially, there's reduced blood flow within the first hours of injury, and this may go on 2 to 3 days after trauma, but may get better as the days go by. So what's our role? It's to enhance cerebral perfusion, blood flow, by reducing ICP, maintaining MAP, and intracranial volume. So cerebral perfusion pressure is the driving force of blood into the brain, whose primary determinant is cerebral, it's the primary determinant actually of cerebral blood flow. CPP is equal to MAP minus intracranial pressure, and the optimum MAP CPP that we need is 50 to 70. So what happens in head injury? We usually find that the blood pressures sort of go up in head injury. Why? Is because you have also a bit of raise in ICP, and therefore the body wants to make sure that the brain is perfused to almost a normal state if it can. Therefore it raises the MAP to counter the raise in intracranial pressure, and hence try to perfuse the brain. The Monro-Kelly doctrine states that the skull is a rigid compartment which has the brain, blood, and cerebrospinal fluid. If we have increase in volume in one of the above, there will be decrease in volume of the other. If we have bleeds, things like an epidural hematoma, extensive contusions, if we have a subdural hematoma, and we have this rigid compartment, what do we expect to happen? So in this, we'll have several components start to decrease within the intracranial cavity, the first of which is CSF. Usually we have CSF within the salcio spaces, we have CSF within the ventricles, and we have CSF within the basocisterns. So as the volume increases, whether there's a hematoma or this edema of the brain, the CSF within the spaces begins to leave and it's reabsorbed immediately. And therefore, when we say that, on a CT scan, I could not appreciate the basocisterns, or on the CT scan there was salcio effacement, it's just one indicator that the pressure within the brain or within this compartment is beginning to rise. So after CSF is drained out of the salcio spaces, the basocisterns, and the ventricles, then the next thing that's usually reduced in volume is the blood flow. So you have a reduced blood flow into the brain, and this will worsen. If there is ischemia, it will worsen the picture. And if this is not resolved, if the hematoma is not resolved, if the brain edema is not resolved, then we start seeing the herniation process going on. So whether it starts as ankle herniation, subfalcine herniation, transtentorial herniation, infratentorial herniation, then finally through the foramen magnum, it's just a cascade of events going on. And as the ICP raises, the cerebral perfusion pressure reduces, and CBF will also try to increase, CBF will reduce also, causing a bit of increase in carbon dioxide. Usually as carbon dioxide is increasing, the vessels of the brain definitely vasodilate to try and increase the cerebral blood flow. Not to forget, as the cerebellar tonsils, the brainstem herniates through the foramen magnum, we'll see a bit of elevated MAP, bradycardia, in order to try and increase the cerebral blood flow. Assessment and initial management. So we have already spoken about the primary injuries, which are skull fractures, diffuse brain injury, focal injuries like epidural hematomas, subdural hematomas, contusions, and intracerebral hematomas. Skull fractures. So here we have those that affect the cranial vault, which could be linear, they could be depressed, they could be comminuted, they could be ping-pong, especially in children, or the skull-base fractures. They could be linear or stellate, they could be open or closed. Open is basically wherever we have a breach in the dura and the CSF leak, then it's definitely an open skull fracture. An early surgical consult if you have concerns. How about base of skull fractures? So these ones, remember the periorbital ecchymosis, the retroauricular ecchymosis, CSF leak from the nasal ear, 7th and 8th cranial nerve pulses. However, if we have a basal skull involving the cavernous sinus, then we have a 3rd, a 4th, a 6th, and a bit of 5th cranial nerve palsy. Diffuse brain injury. It could be mild concussion or severe injury like what we see in diffuse axonal injury. So here we have transient non-focal neurological disturbance that may include loss of consciousness. The CT scan may appear normal on both concussions, even with diffuse axonal injuries. However, patients may be unconscious, so that gives you a telltale that this is probably an injury worse than the CT scan could show. They're usually caused by high velocity impact or deceleration injury, and you may have multiple punctate hemorrhage throughout the hemispheres. So diffuse axonal injury, here you have widespread damage resulting in shearing injuries that occur during rapid acceleration and deceleration, usually associated with poor outcome or severe disability even after patients have left hospital. The grades are 1, where you have widespread axonal damage with no focal abnormalities. Grade 2 is grade 1 plus abnormalities seen in the corpus callosum, and then grade 3 is grade 1-2 with rostral brainstem injury. Post-concussive syndrome. Usually we see these patients, they're quite common in the emergency department, and it's usually disturbing, especially when they are dizzy, with nausea, restless, a bit of memory loss. These symptoms may resolve over time, And then, of course, their CT scans are usually normal. Epidural hematomas. These are usually common after skull fractures. However, in children, it's a little different. Even without a skull fracture, they may have an epidural hematoma. So common in the temporal region due to a tear of the middle meningeal artery. They are biconvex and lenticular in shape. We used to say that they don't cross suture lines. However, if they are involving sutures, let's say the sagittal suture, then they will definitely cross suture lines because it's within the suture. Or if they're involving the lambdoid suture, then you may have injury to the transverse sinus, and therefore they may cross suture lines where you have a bleed in the occipital area and the posterior fossa. You may have loss of consciousness or not. Patients may be talking, telling you the story of what happened, and then they may suddenly become unconscious, what we call the lucid interval. And we have seen the herniation syndromes. If some of these bleeds are not resolved or relieved, then the herniation process begins. So we confirm this by CT. However, if you have a skull x-ray and you see a skull fracture on your x-ray, then it's like suspicious of what is underlying. It could be a bleed underlying. They require urgent surgical evacuation, and we have described why. Subdural hematomas, quite common than epidurals. We see these especially in the severely head injured. We see these in the elderly. We see these in the alcoholics because of the space, the increased space between the cortical veins and the venous sinuses. So the bridging veins are sort of stretched. So even with mild trauma, they will be injured, and they will be bleeding within the subdural space. Diagnosed by CT, and it may be associated with underlying parenchymal injury. And because it's veins that are involved, the bridging veins are torn, the drainage from the brain will not be so sufficient, and therefore they are associated with brain edema from the engorged veins that are not well drained. It will require urgent surgical intervention, and this we will talk about. So contusions and intracerebral hemorrhage. These are present in 20 to 30% of severe brain injuries, but quite common even with mild and moderate injuries. They occur commonly in the frontal and temporal lobes, and they may evolve over time to form bigger hematomas. Therefore, if you have a patient that came in with a GCS of 15 and they had a contusion, and a couple of hours later or days later, the GCS drops to 8 or 9, you are supposed to get another scan to ensure that they don't have hematoma evolution. And depending on the site of injury or the site of the contusion, you may have weakness, you may have motor discoordination, you may have aphasia, memory issues, visual issues, especially if contusions are involving eloquent areas. So repeating a CT scan 24 hours after the initial injury is advised if you can. So assessment of injury, we use the Glasgow Coma score, looking at the motor, the eye, the verbal. And for us to assess the predictors of outcome, we usually depend on the motor score. Why? Because the motor score helps us look at what exactly is going on with the different parts of the brain. What do I mean? If a patient can still obey commands, localize pain, then we know that probably their cerebral cortices are still intact. Now, if they are withdrawing from pain, they still have flexion, they are normally flexing to pain, then we still think that their midbrain is still intact. Why? Because the rubrospinal tract is important when it comes to the flexor tone in the body, and it's located in the midbrain. Now, if they start abnormally flexing to pain, then we know that at this point in time they probably have issues with their midbrain. And at this point we advise that, look at their pupils, because the oculomotor nuclei are in the midbrain. So look at their pupils and assess as to whether they still have them constricting normally. Now, when they are extending to pain and they can't flex anymore, then we are thinking of probably the medulla. Why? Because the vestibulospinal tract, which is in charge of the extensor tone of the body, is basically in the medulla. So if they're only extending, then now we are actually thinking that this is all they have. At this point, we'll ask you, if you call me as a neurosurgeon and tell me that my patient is only flexing to pain, they are not making sounds, they are not opening their eyes, what can I do to help them? The first thing I'll ask you is that, do they still have a pupillary response at this point if they're flexing to pain? The next thing we'll ask is that, do they still have a cough reflex, a gag reflex, or a corneal reflex? Because these are now important to assess how much we can do when a patient can only extend to pain. And then we don't forget that we call it severe head injury if it's 8 and below, moderate if it's 9 to 12, though in some settings it's 9 to 13. We call it mild or minor if it's 13 to 15, or in some settings if it's 14 to 15. So if a patient has mild head injury, what do you want to do for them? Usually they'll tell you they were disoriented, they had amnesia, they had a bit of loss of consciousness, they had a seizure activity. Of course, we want to know how long these seizures were and what was the duration of the amnesia. Serial exams, serial GCSs are really important. And when do you want to do a head scan in such a patient? So if you think that they have something underlying with this trauma, then go ahead and do the scan. If they have a skull fracture, you want to rule out a bleed. If they have 2 or more episodes of vomiting, if they have seizures, if they've had, sometimes they say loss of consciousness for over 5 minutes, some people say 30 minutes. Patients who are older than 65, patients who are alcoholics, patients who are on anticoagulation, patients who have severe headaches that are not controlled with analgesia, high impact injuries or high velocity injuries, patients with focal deficits, and patients who have had multiple injuries. You have to make sure that it's not the head injury that's causing a bit of disturbances in their consciousness. So make sure that you have a neurosurgeon consulted early. And if they are symptomatic, they are awake with no deficits, just observe for a few hours. If they are stable, you can let them go home, but just give them a heads up for what warning signs to look for. So moderate injury. So for all patients with moderate head injury, they need a head scan. Most of these can actually further deteriorate, therefore you need serial neurologic examinations, and they should be admitted at least in a high dependency unit if you don't have space in an ICU. A follow-up CT scan is usually lovely. If patients have had moderate injury and they have a small epidural hematoma, a CT scan within 6 hours of the first scan is really advised. Why? Because sometimes these hematomas get bigger, and therefore the GCS will deteriorate further, and they may look like the severely head injured patients after their next assessment. So what about the patients who are severely head injured? What do you want to do for them? So these ones, make sure you get a head scan as soon as possible after you have ensured that their airway is clear, they are breathing well, their circulation is perfect, they are able to perfuse their brain. If you need to involve ICU, if you need to call the intensivist, if you want them to be sedated, be intubated, this is the time to do that. And then when you're done, obtain a CT scan as soon as possible and consult a neurosurgeon. There are times that we have advised that you give mannitol or hypertonic saline. This depends on the setting in which you are. If a patient has a low blood pressure, do not give mannitol. If it's a child, you may weigh whether to give or not give. So usually we are looking at giving hypertonic saline about 3 to 5 ml per kg. And then as it runs, you can do all these other things. Prior to giving hypertonic salines, make sure you know what the levels of sodium are, because it's hypertonic. You don't want to cause them to have hypernatremia in the middle of having a severe head injury. Mannitol can be given as an infusion at 0.5 to 1 gram per kg. And this, if their blood pressures are okay, if you don't have hypertonic saline, then mannitol comes in handy. So these are some of the images. So we have this patient with they have a bit of bleed there. So that's probably a subdural bleed. It's extensive. They have an intracerebral hematoma, and then they have contusions close to the temporal area, and then they also have more bleeding there. Okay, and then air. So this is probably a fracture with a bit of epidural hematoma. You notice that the falx is not in the midline, so it's highly likely that the cingulate gyrus actually pushed this falx. So this patient already has a subfalcine herniation. And then in image B, we have this patient who had direct impact to the skull. So they actually have a depressed skull fracture, and then also a linear fracture that's extending through to the nasal bone and then the maxilla. Okay. So management of head trauma. So the ABCs are very important. Maintain normovolemia. If you need to use normal saline, if you need to use Ringer's lactate, if their blood pressures are low, resuscitate them as you would other patients with either Ringer's lactate or normal saline. Avoid 5% dextrose because it's a hypotonic solution, and therefore it will worsen your cerebral edema. Monitor the serum sodium levels, even the other electrolytes. Why? Because we want to keep this patient in a normal osmotic state. Elevate head of bed. This has been seen to reduce ICP by about 30%. And then things that you could do. We've talked about mannitol, we've talked about hypertonic saline, we've talked about things like barbiturates. However, if you're going to do a barbiturate coma, then you will definitely need an ICU. Anticonvulsants in head injury, it's quite controversial, but we've seen settings where they are given to all severely head injured patients, as about 30% of them may cease. They've been given to patients with contusions, they've been given to patients who have had a seizure, especially if they've had 2 or more seizures, then they are given. Avoid steroids. Why? Because normally the body per se will produce steroids after trauma, and steroids cause hyperglycemia. So if you have hyperglycemia, the brain will definitely want to increase its metabolism. But remember, it's an injured brain that is trying to, get back to its normal metabolism. So if it's injured and the blood flow is less, Therefore, it will resort to anaerobic metabolism, and this has been known to cause very poor outcomes in head trauma patients. Therefore, we avoid steroids, we avoid hyperglycemia. If you think they're hypoglycemic, then we give 50% dextrose. We usually give a meal package until they are normal glycemic. We hate hyperglycemia in head trauma patients. There are other things that we could do, things like sedation, things like hyperventilation, but this should be controlled. Things like making sure that we do bar holes and then do ventriculostomies, drain CSF in case the pressures are high. When you do ventriculostomy, you can monitor the ICP, and when the pressures go up, you sort of drain off some of the CSF. We'll look at what it entails in the operative session. And then, of course, in some settings, once the edema is not controlled, then decompressive craniectomy becomes the other option. We'll also talk about that. So what would we do in our setting or in any resource limited setting? So if you cannot obtain a CT scan, the skull X-ray is not obsolete. It can be used to diagnose, and it can also be used as part of your decision making as to whether you want to do surgical or non-operative. So this can help us assess for base of skull fractures, pneumocephalus, linear fractures like we see there. We have a fracture there. Okay. And then depressed skull fractures, and then comminuted fractures. Remember, if you have patients with skull fractures, suspect that there is brain injury or an intracranial bleed, whether epidural, subdural, could be anything. So sometimes with the skull X-ray, especially if the pineal body is calcified, you may be able to assess for a midline shift, penetrating injuries with retained foreign bodies, and then scalp hematomas with underlying fractures. So skull fractures should be considered as having an underlying bleed until proven otherwise. Simple linear fractures with intact patients, usually we manage conservatively. Depressed skull fractures with neurologically intact patients can be managed conservatively. And then if we have fractures with deficits, if we have fractures with either weakness on one side, with a dilated pupil, with a falling GCS, with seizures, then we may need to do something operatively. And here, either whether you yourself do the bar hole or do the decompression or consult a neurosurgeon, I mean, it's urgent. It's an urgent thing to do. Okay. And then how about patients who have GCS 8 and below and you don't have a ventilator? So with this, we have actually tried to do something about their airway protection. In a setting, we had studies where we did tracheostomies, and when these are done, at least we ensure that the airway is clear, and they can be nursed in a high dependency unit. So these interventions should be done together with other aspects of management of head trauma. Otherwise, thank you very much. I would like to thank the team, the trauma team, the team down at casualty, and the neurosurgical team. And thank you for listening. In case you have any questions, please do not hesitate to air them out to the neurosurgeons that are on the neurosurgery ward, or even the residents that are on ward. I know that you will be able to get answers to your questions. Thank you very much.